Good morning, guys. I'm Matt, and this is Hannah, Uptown Orthopedics.
Oh, and I'm mental health nurse for gastro.
So we've been hired to kind of look at mental health patients in AVH. We all have patients for mental health issues, but with physical health issues as well at the same time. With pulmonary orthopedics, we found that patients are coming in with pulmonary orthopedic issues, but also having trauma, mental health issues, and a bit more input for the staffing and the team in regards to how to manage the patient and support for the patients themselves.
So obviously I do the very same role, but over on gastro, so our patients predominantly have sort of alcohol, which they tend to be detoxing, very confused, a lot of the time not got capacity, so not really fully knowing what they're doing. It's just about supporting the staff in how they manage these patients as well.
So we're covering what is the role of mental health liaison nurse and how it's come about. What do we do differently to patients of our nursing colleagues? How have our skills helped to manage and prevent instances of AVH by patients? Our experience of AVH in our respective areas. What changes we made to lessen AVH incidents and improve patient safety? So we started off with our role come about. As we were aware, mental health is getting worse and worse. In fact, during COVID, we saw a humongous spike in people having mental health issues, not only raising it, but having more difficulties themselves in society. That can be attributed to the fact that people are more isolated from people are more recognising that their own mental health is difficult as well.
So, as we've said, we kind of cover different patient areas. So we do find that some of our patients have different mental health needs, although some have very similar. We've got patients that are coming in with the complex needs anyway. And then, as I say, adding that detoxing on top of it, or in Matt's area, gets a lot of sort of dementia patients that are very confused as well. Adding them different elements to somebody is causing more problems with mental health to become a little bit worse rather than an unfamiliar environment.
What it also means is when someone's discharged home, it's less likely to come back to hospital at some point in the future. We're keeping people out of hospital for longer periods of time. We all have a frequent flyer patients possibly coming into ED and places like that. You have your neck of femur injuries, you have isolations, dementia and delirium. It helps the team to help us, to help yourselves, to provide a better quality of care. It also help with the legal aspect as well in terms of capacity act goals and stuff like that, making it easier for people to understand if someone does need definition of this team put in place. So kind of covering a very wide area. What we do differently to our nursing colleagues? I think one big thing I'd say we do is we've got more time on our hands. Because we haven't got a bay, so we can say, for example, a bay or something like that. We've got more time on our hands. We can sit down with that patient, talk to them, get the full picture of what that patient's issues, concerns are, potentially risk as well. We've had patients on the poor trauma peaks, we've had high risk patients of violence and aggression. So by taking time to understand that patient, what their trigger points are, what their factors are, what their risk history is as well, it allows us to communicate with the team, provide a risk formulation document about what that risk is, what the concerns are, what to look out for, what they can put in place to keep the team safe and keep the patient safe and other patients safe as well.
And also finding that collateral history for the patients, what's worked in the past for them, have they already got mental health support that we can implement onto the wards, that we can follow through in the community to, like you say, try and prevent that reoccurrence for the patient as well, to support our staff. Obviously, we've got quite a lot of experience around de-escalation and what that may look like for the staff on the ward. Excuse me. So we can educate our team members around how to de-escalate a patient to help prevent some of their AVH incidents happening as well.
As was highlighted earlier, some of our patients with violence and aggression can sometimes not have capacity to understand, and that's no matter if we put someone in a one-to-one. When we put someone in a one-to-one mental health, we might consider having a one-to-one care plan in place that helps us structure the teams one-to-one, helps us support the team and look out for, as well as finding some guidance, because we all know that mental health and physical health care is 24-hour service, but we're not going to be here 24 hours a day. So by having a care plan helps the team to understand what to look out for at any point in the day, any point at night, and something to fall back on if it's needed as well. How have our skills helped manage and prevent instances? We've been over this a bit. But we also look at different medications. We have got de-escalation and medication plan in place for different patients. Obviously looking at Razpam IM, looking at different medications. We also look at the reason why as well, the reason behind why the person's getting aggressive and violent. Because by looking at that, we're not only looking at reducing the reason for violence and aggression, but the causative factor behind that as well, which does help a lot in our management of patients as well in the long and short run.
And obviously NUH has already got its own policies and procedures in place. So we're just re-educating the staff, making sure that they are familiar with them policies and following the right structures as well to support the staff, the patients, sorry.
We also do a lot of emotional engagement as well. A lot of our patients come to us in crisis or feeling emotional crisis, and sometimes it's a case of having a time that talks, saying, how do you feel, let's go over it. Let's turn something in a crisis point into something a lot less than a crisis and help them to recognise what is crisis and what is an emotional reaction to bad news and bad grief news. Because we do have chaplains here and stuff like that, but they aren't, again, here all the time. Sometimes they need someone to talk to who's been given bad news. In orthopaedics, quite often, amputation or something like that, it's someone to talk to. It's helpful to have someone who can sit down and go through it with them and help them to rationalise and break things down. Is that okay? I experience myself.
So, as you say, because we work in different areas, our experience of the AVH that the staff experience from patients is very different. We get a lot of verbal aggression in gastro. They can be very, very physical. There've been some quite extreme situations where staff members are getting hurt by not only sort of being hit, kicked and spat at by the patient, but they're also picking up the furniture and trying to break the windows or trying to get out in some other ways. So it's about knowing how to manage safely these situations, making sure that we've all got the right systems in place. So we've got the personal attack alarms, just going around making sure that staff have got them with them, know how to use them, know that that means that security can come and support us, and then putting the plans in place to try and prevent these AVH incidents happening again.
As a ventral orthopaedic, we see anything from dementia patients who come to hospital with delirium, possibly grabbing at their wounds that they don't realise are broken and needing someone to support them to recognise that the leg is broken, that you can't cause more damage to it. To the patients who possibly have a brain injury caused from a car crash and they're not understanding what's happening and causing violence to staff and patients on the ward itself. So we've had a very broad spectrum, including as well, I think the less known for us about area, patients causing violence themselves as well and self-harming injuries as well, which is a big thing that we don't seem to. It's a very difficult thing for people to understand, both for staff and for patients as well, for patients experiencing it, but for the staff who maybe haven't got that background of experience in doing people self-harm. It's difficult for a member of staff to see someone doing that and be able to say to themselves, how do I feel after seeing that person do that? So a big thing for us is looking at that as well. Yeah. We've had a patient recently who did that with an FA team. So it's about offering team time after in our own role by saying, we're here to support you. The well-being is there, but sometimes it's a case of saying, well, I know you, I can talk to you, I can be there with you, you're here. What changes made in looking into areas to lessen AVH incidents?
So again, we've looked at ways that we can try and prevent or reduce the AVH incidents that may happen on the wards, may occur. So it's about encouraging staff to report them incidences, because a lot of the time they weren't doing that, or they haven't got the time to sit down and fill out, say, a Datex form. But it's about letting them know that that's the way that we can make change, and that's the way that we can look at what differences we can make and what we can implement and how we can get extra sort of staff if we need it, for example. So if they've not got the time to sit down and fill out a Datex, we've considered maybe having a book in place so that we can sort of handwrite, jot something in, we can retrospectively then fill out them incident forms.
But a lot of the time it comes down to knowing helping the team to recognise, giving the team time as well. So that might be a case saying, I'll volunteer 5 minutes, you guys go and do something to help yourselves out as well, and do what you need to do to get the paperwork written up and done and stuff like that. A big thing we also look at is training staff to recognise what's happening with the person, helping that team to kind of have a broader understanding of what's going on, that the person maybe hasn't got capacity or has got capacity, and then from there looking at how you might approach that person. Where a person without capacity, you might approach them in a different way to a person with capacity. And what's more, it comes to recognising what might be, for example, delirium has been a big thing for us. So recognising what is delirium, what it looks like, how to treat it, how to manage it, and how to keep it from being there, then letting it get to there, managing incidents so they don't come to the point where someone's getting hurt, and we're keeping it as low level as we can, where reasonable, where possible.
Oh, sorry, and I was just going to say, as Matt's touched on before as well, just making sure that then we're offering staff that debriefing time or that time to reflect on what's happened, and we can offer that support to staff as well, because we know that these incidents are quite challenging and can take the toll on staff mental health as well.
So,
yeah, there we go. Any questions for us, little guys? Yeah.
Hi, I know that you've mentioned de-escalating quite often. I know generally it's you talking to the patient and trying to calm them down, but are there any techniques that you've seen that actually work? And can you share some of that with us?
So it varies from patient to patient really, which is where it becomes a little bit difficult. Because as you say, you can talk to people in the face, but some people just will not respond to that. I think a lot of the time is if you can see that build up, that like sort of trigger signs to it. So if you can see, again, it's different in all patients, but if the patient's like getting sort of like making fists and that sort of, you know, aggressive kind of notions before they get into the point where they're really heightened, can you distract them in any way? And that's kind of where our mental health nurse role comes in as well. We're sitting with that patient and their families and finding out whether they've got any techniques that they've already used in the past, or, you know, if you've got a confused patient, your About Me documents are amazing because you've got all the things on there of what they enjoy doing, and if you've got any activity sort of available on your ward, you can maybe use a distraction technique with them before you've got to the point where they're really heightened, and then you've got to try and bring that patient back down. So that's probably one of the best things to try and do. Sometimes if they're already up there, just if they're in a safe environment, letting them be, and just let them kind of work it out for themselves rather than constantly trying to, you know, staff kind of gather together normally, don't they, because they want to support each other and they're worried. And sometimes that's the most unhelpful thing that can happen because you're just kind of continuing to escalate that situation. If they're in a safe environment, I just let them kind of work it out for themselves, like I say, as long as the patient's safe.
We use the LEAPS model: listen, empathise, ask questions, paraphrase, summarise. It's just a way of communicating with the person, helping the person to recognise that a lot of times people feel aggressive and don't have capacity because they don't feel listened to or they're in pain, and they're best to saying that I've got these concerns, but also to communicate that, they just shout it out at you, to feel listened to by that way of saying, like, you know, let's go through your problem, take your time. It's a difficult thing in the environment that we're working. My background, we have like a spare room we can go to, a quiet room we can go to, taking someone from that loud environment to somewhere where it's a bit more quiet, a bit more one-to-one. You can sit down with that person, de-escalate them. But I know in the bays it's a lot harder to do because you get people around you, beeping and noises and machines. That's one thing I can always advise. If you've got somewhere you can take someone to sit down with them and talk to them, that will make a massive difference to the person. Like Hannah says, if you've got 10 people around them at once, they're going to possibly react and say, well, actually, I'm feeling threatened right now, so I'm going to react to that by escalating my own behaviour. Does that make sense? Yeah. It's just a case of protecting yourself and protecting your team, but not escalating the situation. Any more questions?
Thank you.
Thank you, guys.
All right.